Hey, hi there. Let's go ahead and get started. Welcome. Thank you for joining us. I'm Lindsay Esri. I lead 0 to 3's policy and systems building work focused on perinatal, infant, and early childhood mental health. And I'm going to get us oriented and settled with our agenda and introduce our speakers, and then everybody else will take it away. Next slide. First, for a little bit of housekeeping, we will be recording today, and the recording will be sent out to everyone who registered. If you have questions as we go along, please do put them in the Q&A section, and our team will be monitoring those. We'll try to respond to questions as we go along, and we'll have a little time for discussion later, so we'll also try to pull some questions into our discussion time. And please feel free to say hi in the chat. Let us know where you're tuning in from and what you're excited to hear about today. We're excited to see who's here. Also, today's session is brought to you by our IECMH Financing Policy Project. And if you're unfamiliar with that project, in a little bit, I'll put a link in the chat to where you can find more information. We're going to be welcoming new states into the project in spring of 2026. So if your state isn't already a part of that collaborative and you're interested in joining, please do get in touch with our team. Myself or Kathy would be happy to connect with you. So today, let's get into the meat of it. Today, we are talking about how through certified community behavioral health clinics, or CCBHCs, through the CCBHC model, states and communities can effectively meet the mental health needs of young children and their caregivers. And we'll be talking about that, referring to it as infant and early childhood mental health, or IECMH. We've seen that as the CCBHC model rapidly expands nationwide, it is transforming the public behavioral health system. And because CCBHCs are required to serve individuals across the lifespan, they offer a really powerful and unique opportunity to thoughtfully integrate IECMH services and to build really strong partnerships with broader early childhood and mental health systems. We are very excited about that opportunity, as are all the colleagues who are joining us today. So today we're releasing a new toolkit on this topic. And in this webinar, we're going to provide an overview of the toolkit, the contents, and give you a sense of what's in there and how it might be useful to you. And we're also going to explore how state agencies and local clinics are developing their services for children aged 0 to 5 and their families. Next slide. So the toolkit seeks to do some of the heavy lifting for you in terms of showing how developmentally specific services really fit into the CCBHC model. And it also seeks to promote partnership across systems to best meet the needs of families. And you'll hear us talk a lot about that cross-systems integration today. And we know that our audience for this session is varied, and you might be bringing really different perspectives into the space. Some of you might be tuning in because your work focuses on CCBHCs and you're figuring out how to meet needs across the lifespan, and that perinatal, infant, and early childhood piece might be newer for you. Others of you might be joining because you're infant mental health or early childhood leaders, and you want to understand how CCBHCs might fit into the broad continuum of care that you're seeking to ensure in your state or community. And we are really excited about that intersection. And we hope that this toolkit and our conversation today will support bridging and deep collaboration across those worlds and perspectives and support that kind of work in your communities. Next slide. So why does this matter? If you've ever joined any talk hosted by 0 to 3, you have surely heard us discuss that the prenatal to age 5 period is a critical window for children's emotional, cognitive, and social development. We know that during these foundational years, strong, securely attached relationships, nurturing environments, and responsive caregiving are essential to healthy development and mental health. And we know that caregiver mental health is critically important, even beginning prenatally. And so we want to make sure that we have systems of care in communities that are proactively recognizing and meeting the mental health needs for pregnant and parenting adults, and that's really important for the well-being of babies. And we know that young children can and do experience mental health conditions at roughly the same rates as older children. And in many places, our healthcare system is poorly equipped to meet those needs in ways that are developmentally appropriate. This is an area of specialization that isn't represented necessarily in all mental health service delivery spaces. And we know it requires specialized support to build out those developmentally specific supports and services. And so this is a really important opportunity for partnership. Next slide. So today you're going to hear from our dear colleague Anne Mukherjee from the National Council for Mental Wellbeing. She's going to talk about the CCBHC model. The National Council does incredibly important work to support CCBHC initiatives, and we're really have been so fortunate to collaborate with Anne on this work. And then you're going to hear from Lisa McGarry and Kathy Bodkin from our teams at 0 to 3, and they will be highlighting elements of the toolkit. So Anne, I'm going to hand it over to you.
Thanks so much, Lindsay. Just a giant thank you to 0 to 3 for inviting me here to kind of ground us in what CCBHCs are. And Lindsay, you did such a great job of outlining the why. So I'll just add a little bit more to the why CCBHC question. So we know that there's increasing behavioral health needs among children and youth. And when those needs aren't met, that burden tends to fall on other systems. So when we're talking about the IECMH space, that might be child welfare. As youth get older, it could be justice system involvement. We see disproportionate school discipline, not only in grade schools, but preschools, even caregiving. And so all of this unmet need really starts to drain not only our behavioral health system, but other systems that children are involved in. And so we also know that there are evidence-based practices out there that can support this, but still struggle to get those out into the world to the people who need them. So on our next slide, we'll see CCBHC is really very intentionally trying to solve for some of these long-standing systems challenges that I'm sure folks in this room are really familiar with. We like to think of CCBHC as a three-legged stool that is pairing a comprehensive clinical model with a quality measurement program and a sustainable financing mechanism. So quality, clinical model, and financing all wrapped together to have this really comprehensive model of care that is moving the needle not only on the quality of behavioral health care that people are receiving, but access to that care as well. CCBHCs are required to serve anybody who walks in the door seeking mental health or substance use care, regardless of their ability to pay, their place of residence, or their age. So as Lindsay mentioned, this is a lifespan model, and lifespan means lifespan. It means young kids and their families can get care at CCBHCs. CCBHCs provide integrated, evidence-based, trauma-informed, recovery-oriented, person and family-centered care, a full array of mental health and substance use care, and that care is coordinated with both non-health and health care providers in the community. So on our next slide, we'll see CCBHC is grounded in best practices. So this model wraps up what we know from decades of behavioral health, public behavioral health services, and starts to put in place this really comprehensive approach to starting to meet all of those needs that we talked about and grounded in at the beginning. So it's a greater scope of services than most of these clinics have provided previously. It has that active collaboration component. So it's not just providing services, but it's ensuring that it is fully family-centered, individual-centered, and looking at the care needed for them to really meet their personal goals and care for their behavioral health needs. It's also driven by the state and local needs. So at the bottom of this slide, you see the other sort of framing we have around the model. So it's federally defined. SAMHSA and CMS have those federal definitions that are the foundation of the model. States then get to build upon that to meet any system goals that the state might have or other initiatives using CCBHC as a vehicle to improve public behavioral health systems. And then finally, it's the clinics themselves at the local level that really achieve the vision of the model. And so clinics do a community needs assessment and build further upon those federal definitions, the state driving, and then meet the communities where they're at by identifying those needs and building a service array that meets communities where they need supports the most. And then finally, this model really focuses on meeting people in the community outside the four walls of the clinic. So on our next slide, let's take a look at what's actually in the CCBHC model. So it's grounded in 6 domains and 9 core services. So those 6 domains across the top: staffing, availability and accessibility, care coordination, scope of services, quality and reporting, and organizational authority. The thing I like to highlight here is that scope of services is only one of these 6 domains. When we think about behavioral health care, we tend to hone in really on services. What I love about this model is that it takes into account all of these other components that are required to make those services as effective as possible. So a comprehensive staffing model, requirements around being able to actually access those services in a timely manner when you need them. Coordinating those services with all the other needs we know individuals have and their families. And then we get to the scope of services so that all of these 9 core services can be as effective as possible. So those 9 core services, these are required in the model, really span the continuum of behavioral health care. So we've got crisis care, screening, treatment planning, outpatient mental health and substance use, primary care screening and monitoring, targeted case management, psychiatric rehabilitation, peer supports, and then care for uniformed service members, veterans, and their families. All of these are person and family centered and wrap up into this that federally defined criteria that CCBHCs are meeting across the nation. So on our next slide, let's talk about where CCBHCs are. This started as a federal demonstration in 8 states with 66 sites in 2017. Now there are over 500 CCBHCs operating in 46 states, DC, and Puerto Rico. That's coverage of 40% of US counties and over 60% of the nation's population. On our next slide, you can see what actions states are currently taking. So as I mentioned, there is a federal demonstration. That's the financing piece. So we've got the clinical model, the quality program, and then the demonstration pairs in the Medicaid financing that offers that sustainable financing to meet the cost of doing these enhanced services. So there are 18 states in the federal demonstration. States have also moved and sustained the model outside of the demonstration or pursued it on their own. So those dark blue states there are 5 of those states. And then we have 15 states currently that are planning for applying to the demonstration. And there will, from that group, new states will be added to the demonstration next year. And so those are those light blue states. Finally, SAMHSA has also offered, outside of those state-driven methods, individual grants to clinics to start to build up the services required under the CCBHC model. And so all of those states in that light tan color have at least one grantee where there's a clinic in their state building out the CCBHC scope. So on our next slide here, what I want to leave you with, again, is that this is a lifespan model. So when you're listening to folks today, we are talking about IECMH. IECMH is part of CCBHC. It's a lot of acronyms, but they're all important, and we are working to put it all together. So lifespan means lifespan. Developmentally appropriate services should be available for all ages, from infants and toddlers to youth transitioning into adulthood. The needs assessment that CCBHCs do really drive the service development and can help those CCBHCs figure out what are those IECMH services needed in their community and build their service array to meet those community needs. And then finally, there's flexibility in the model so that clinics can identify the developmentally appropriate care that is best suited for the community that they're serving. So we know that evidence-based and evidence-informed practices exist for all ages, including young children, and they can be incorporated into the CCBHC service array and payment model. I'm really excited about the conversation today because we have a model that we know is working. We have data to show that CCBHCs are moving the needle for care in their communities. So having a toolkit like this that pairs together the CCBHC model and the opportunity to use CCBHC as a vehicle to move the needle in IECMH is really exciting to me. And I'm happy to hand it back over to Lindsay so you all can dig into the toolkit.
Thank you so much, Anne. That last slide, I think, really just hits it. It's a home run for me. Lifespan means lifespan. I think I need a t-shirt that says that. And I will say in my position, have gotten to work on a lot of different federal and state policy issues related to mental health of young kids. And it's actually incredibly rare that something is so explicit, that we're so explicit in a funding stream that young children are definitely included in the population served. And that is such a huge opportunity here. So really excited, and thanks Anne for underscoring so much of that and giving us that kind of foundational grounding. If you're not familiar with CCBHCs coming into today, now you have some foundational content there. And similarly, if you're not really familiar with IECMH coming into today, I'm going to do just a couple minutes on some foundational content, underscoring some things that Anne said, and then we'll get into contents of the toolkit. So what is infant and early childhood mental health? Here on this slide, we're sharing with you a commonly used definition of infant and early childhood mental health. And when we're thinking about a continuum of supports and services for young kids, from promotion and prevention services through treatment, we're thinking about promoting and preventing these capacities, these developing capacities in the child. And we're thinking about providing intervention or treatment when conditions arise that are interfering with these developing capacities. And on the next slide, I want to talk a little bit about, alongside that definition, which is framed in a very child-focused way, we also like to share some of these other kind of foundational concepts that are central to the work of infant and early childhood mental health, but that might not be explicit in that definition. The work itself is very family focused and dyadic in nature. So we want to underscore, when we're thinking about infant and early childhood mental health, the importance of relationships and family focused approaches. That is what developmentally specific and appropriate care looks like for young children. And again, repeating for the folks in the back that young children can and do experience mental health conditions, diagnosable mental health conditions, and conditions for which we have effective and developmentally appropriate approaches to recognizing and addressing. And importantly, this care looks different and it requires different specialization than standards of care for older children or adults. And so there is this opportunity in lifespan care delivery to really think about developmentally specific approaches. And lastly, we want to note that our language is always evolving and there's always nuance in our language. And it's particularly important for us to be mindful of this when we're working across systems and when we're looking to integrate work across sectors or disciplines or settings. So depending on which system you're talking to, if you're newer to the early childhood space, you may have partners referring to this work as social emotional development. You may have partners talking about early relational health. And at 0 to 3, we really conceptualize infant and early childhood mental health policy and systems building work as encompassing of all of that. These terms are all really talking about these kind of this core foundational focus. And so we always want to be using language that's inclusive and kind of resonant with the different partners that we might be collaborating with. Next slide. We again just want to underscore that systems piece, that none of the challenges that babies and families face are happening in a silo of health or education or substance use disorder treatment. And babies and families aren't thinking in terms of programs and systems. So the more integrated a system providers can create and collaborate to establish, the easier it is for families to navigate and receive the services that they need. And CCBHCs present a really powerful opportunity within what is hopefully a quite integrated ecosystem of support for families. So now that we've covered some foundations, we are going to get into introducing you to the toolkit. So I'm going to hand it over to my colleagues at 0 to 3. Lisa is going to provide an overview of the first element, the brief, and then Kathy will share a bit about the integration and implementation tools and show you some highlights from those. After we go through the toolkit, we'll talk with some leaders from states and communities to get some state and local perspectives. Lisa?
Thank you so much, Lindsay. We're so excited you all are here for our first look at the toolkit with us. And I'm so thrilled to share a bit about the first document we developed for it. It's called Certified Community Behavioral Health Clinics and Infant and Early Childhood Mental Health. In this brief, we explore questions that our team has received from state infant and early childhood leaders about CCBHCs over the last few years. And what's bubbled up to the top is that we are sitting at a very unique moment. We really have an opportunity to rethink what the public behavioral health safety net can look like for families with very young children. We've learned that there are incredible opportunities for early childhood leaders and practitioners to partner with CCBHCs. The graphic here reflects the 9 required services that Anne actually referenced earlier as well. And Kathy's going to walk us through those a little bit later. I'm not going to unpack that with you for time's sake. But we do know that there's still a ton of work to do to integrate IECMH into CCBHCs, from state level policy to local level practice and policy. So we're hoping that this toolkit provides some important context for starting or continuing. Maybe some of you have already begun this journey, continuing the conversation in your state or community. You can go to the next slide. Next slide. We were thinking about a couple of different audiences for this brief. So really thinking about early childhood leaders. Folks, many of you have seen some familiar names on the call today. You are leading early childhood systems building work, or IECMH leaders. We're also looking towards those folks who are clinic leaders for CCBHCs, those involved in state level policy development for CCBHCs. We're trying to bridge a connection between those spaces. We know there are folks with expertise that want to be involved, and we need to figure out how to bring all the folks together to the table and make sure those conversations are happening. And sometimes those conversations or those connections aren't necessarily ongoing. Maybe we partnered for specific projects or, here and there, but early childhood and behavioral health don't necessarily always intersect in the way they need to in order to think about the development of CCBHCs. And the whole idea is to share around best practices and informing so many of the areas that I'm going to talk about on the next slide. So really critical question for us that we were asking ourselves all along this way is, why is it so important for infant and early childhood leaders to get involved in CCBHC implementation? Well, you can see 6 areas here that we've identified, and there's more than just this. Kathy's going to talk us through some additional layers to this onion, so to speak. But what bubbled up for us were these 6 areas. And one that I'm going to talk you through today is around the community needs assessment. I don't have time to go through all these, but hopefully when you dig into the toolkit, you'll be able to see more and think more about each of these distinct areas. So one of the initial steps that Anne mentioned earlier for CCBHC implementation is doing that community needs assessment, or CNA. And that's really important to the startup process. And it's also really important to ongoing implementation, as clinics must reassess every few years. And it really informs the CCBHC's understanding of the strengths, the needs, and gaps among specific populations, including very young children and their families. It also informs infrastructure decisions, staffing, training, physical space, and the development of the cost structure, which is really critical and different than some of the other ways that behavioral health has been funded in the past. So early childhood leaders, providers, and families with young children are all important informants for the CNA process. Without these perspectives, it's very challenging to build an integrated care setting for families and babies. So we really need to bridge those connections so that those voices are informing the build. Early childhood leaders can be asking good questions along the way about the CNA process, including how frequently that assessment process is required to happen, and whether there are key partnerships and data required for the community needs assessment. And are those required data points and partnerships inclusive of early childhood perspectives? So you'll see kind of thinking like that frame, that angle across these 6 unique areas that we talk about in the first brief. And we'll go to the next slide. And just to give you a feel for what it will look like when you see it and what you'll find when you get in there, I just wanted to call out one section. So I know that that screenshot there is teeny tiny, but you'll hopefully be in the full document soon enough. But this section is one of the areas referenced on this last slide, informing the prospective payment system rates. And the PPS rates is what they're referred to in shorthand, are critical to understanding the potential for IECMH service delivery within CCBHCs. So in that section, we describe the basics of that rate structure and how it works. And we also link to some additional resources from the National Council, including their PPS cheat sheet, which is essential reading if you really want to get into the specifics around how those rates are structured and how they're different from past rate structures like fee for service. You'll also find definitions and analysis in each section, and you'll see that we've included key sets of questions throughout that may be helpful in guiding conversations between infant and early childhood leadership and CCBHC leadership. Next slide. So one last piece that we included in this first brief was an appendix that was a scan of state certification manuals that were available. It was late 2024 when we were doing that scan. Just so you know, there's a little time in between when we did the scan until now. And so we looked at what was publicly available at that time, and we found manuals from 12 states. So why would we do this? What were we looking for? So we're really looking to see if state certification manuals for CCBHC really reflect the needs of babies and their families. So do we see language in those manuals that calls out a specific workforce? Do they mention the needs of that population in their community needs assessment requirements? Is there anything mentioned around that population in evaluation and diagnostic services or treatment and consultation services? So we looked across those domains and pulled it into a chart at the end of the document so you can see our findings there. And I think our conclusion was that there's still a lot of work to do to really reflect the needs of babies and toddlers and their families in policy language within certification criteria. A number of states, we didn't find any reference to this population. So we're hoping that the examples we did find, which a few states did have language, will be something to look toward as other states want to develop this language and improve the system. So a few states that we call out in the brief that did create language around babies and toddlers in the manuals include Michigan, Minnesota, and Oklahoma. So we hope that you all will think about that more as you start to get more into the work of CCBHCs and bridging those connections with IECMH and other early childhood supports and services. And with that, I'm going to pass it off to Kathy to walk us through the other documents in the toolkit.
Well, thank you, Lisa. I'm so happy to be here today and to begin talking about this toolkit. We've been very aware that there was a need to support the conversations across the early childhood system about how to support the development of the CCBHC model. And this toolkit doesn't provide absolute answers to anyone. It's just initiating that conversation. We hope to stimulate cross-system discussions, but also creation of innovations about how to respond to the needs of young children and their families. So this second document about integrating infant and early childhood concepts into the 9 required community services, we emphasize the idea that there are already services developed and each community is very different, but the different opportunities exist. And so as you look through this particular document, and it takes you through each of the 9 services, and it talks about the services and partnerships or the workforce development, your own community, your own state may have already tried some of these, but we're just encouraging you to kind of open up the discussion and think differently from the lens of what does the early child, the infant and toddler, young children, what are their needs? And this starts with the community needs assessment. They can identify gaps in the infant and early childhood mental health system and then identifying the priorities for the greatest needs. And then in that discussion, hopefully across system with different partners, who would be the appropriate person? Where's the appropriate place for some of these services? Getting family input on this so that it is family and driven. And would this be a service that the CCBHC itself would develop, or would it be one of the designated collaborative organizations that a partnership would be formalized with? Go to the next slide. And so if we take as an example, one of the 9 services, the second one, which is screening, diagnosis, and risk assessment, often, this is described in the SAMHSA document about the criteria. And you'll notice in this definition, it suggests referrals for specialized services and use of telehealth, which is possible in serving families with infant and early young children. Next slide. So we take that service and match it with where there might be some opportunities for services and partnerships. Depending on the community system and the pathway from developmental screening in a pediatrician's well-child visit and through perhaps a community referral system to the CCBHC for a full assessment may work very well, or there may be some ways that you could strengthen that by either providing training or discussions with those pediatric providers, adopting common assessment tools across your community. We found that in several communities, the screening and assessment tools for children under 5 had not been identified. And so here's, suggestion that area be explored, and maybe as a clinic, but also with your referring sources to identify the assessment tools you want to use. And this strengthens the system in terms of how it's providing services for families, because they're hearing common messages from the healthcare provider, the behavioral health provider, the child care provider, and it makes it more clear for the families on what is being discussed. And the toolkit provides other suggestions that you may have already tried, but one of those that we found has really strengthened the system is the infant and mental health consultation support for the clinical providers. This could be the CCBHC itself providing this to other providers in the community, or it could be that the clinicians within the CCBHC are receiving mental health consultation and reflective supervision. And those are tools that we know keeps people from burnout in the system. It retains staff and really improves the quality of services that are provided within the system. So these are, again, some suggestions of what could be provided in partnerships or services. Next slide. And we looked also with each of the 9 services at what were the workforce development implications. And we strongly suggest really that everyone, whether they're serving children or the adult services within the CCBHC, that anyone providing services could benefit from basic training on infant and early childhood mental health concepts, as well as early developmental stages of young children. And we think of services also from the idea of promotion and prevention, not just those that have are needing treatment. Sometimes in the screening and risk assessment, what might be the outcome of that is that you would find that the child, the family's very anxious. They're not sure if the child is developing appropriately. And with a brief intervention or some parent education, this family will be on, and the child will be in a better position. So this is a really important stage to have the community coming together and identifying, again, those assessment tools and looking for the family strengths and needs. The DC 0 to 5 is a diagnostic classification that's explained further in this document. It's for children 0 to 5 that looks at developmental and relationship factors. It's different from the DSM-10 or 11. So that's also something that we want everyone to be conscious of and familiar with. Next. Also in this document is a guide, a 15-question discussion guide for staff to look at their own operation and how the CCBHC or the state system is connected to the early childhood, broader early childhood system. And there are 15 questions. There's a couple examples here about the internal operations, and again, how the treatment plans might reflect that relationship approach when working with families or an individual and they have young children. One of the major areas we found that is a weakness in all of our systems and wherever we are in early childhood providers is really how the data is collected. And it's very unusual for a system to have any data that breaks down the 0 to 5 group into, for instance, 0 to 2, 3 to 4. Usually there's just children under 10, sometimes children under 15. So we really all need to look at how we're collecting our data and evaluating quality for different age segments. Next. So the third document in this toolkit looks at implementing the IECMH services more from the perspective of the leadership of the CCBHC. And how the existing clinic structure or organization could be more responsive to the needs of infants and young children and their families. Next. As I mentioned, the continuum of IECMH services goes from promotion to treatment. And we look at the full continuum when we're talking about infant early childhood mental health and identifying those kind of mental health conditions that the family conditions, the risk assessment, and housing, the environment, all of those factors that relate to the young child's well-being. So one of the ways we started talking about how CCBHCs might enhance the services for young children and their families is in adult treatment, still being aware that the child and the adult, as treatment develops, there may need to be a plan for a healing of the relationship between the young child and the adult who was either being in treatment with substance use disorder or severe mental health experience. So the parenting role may need to be strengthened, and we just urge CCBHCs to include that in their assessment and to reach out to their community partners who may be able to support the parent in their relationship with the child. And then the dyadic treatment, we'll talk about that a little bit more. So if we look at the program requirements, program 2, each of these 6 program areas, we identified key strategies that could be implemented to improve the quality of any one of them. Excuse me. And suggest how those might be implemented. Excuse me. So you may have tried some of these, but we hope this will stimulate your thinking and start innovations. And you can go to the next slide. So under 4, as you're aware, the 9 services are listed. So we took each of the 9 services and identified a key strategy for that service, and then identified sub-strategies. so that it is more fully developed. And the sub-strategies really look at the different partnerships or approaches that could be taken. For instance, with the crisis services, developing a kit of comfort items that a child might need as the team is dealing with an adult caretaker or parent that's in the home, and possibly an ongoing list of appropriate services that would be child specific that you would want to refer a family to, and training crisis teams on infant and early childhood mental health. Next slide. So in this document, we also have links to the appropriate screening tools and clearinghouses on evidence-based, evidence-informed parent education and treatment models, and then other resources from 0 to 3. So I'll pass it back to Lindsay.
Thank you so much, Lisa and Kathy. So now that we've given you a little walk through the toolkit and you have a sense of what you'll find when you go and download those components, now we're going to talk with some state and local leaders about state and clinic level implementation and integration. So in our next slide, I want to introduce you to Lisa Buckheister, who you'll be hearing from Kansas's Department of Aging and Disability Services. Linda's going to talk about a state level perspective, and then we're going to hear about a CCBHC level perspective from Sarah Kelly Palmer with Family Service of Rhode Island in Providence, and from Christine March with Family and Children's Services in Tulsa, Oklahoma. So Linda, I'm going to go ahead and pass it over to you.
Good afternoon, everyone. It's lunchtime here in Kansas, so not used to saying afternoon yet. You could go ahead and go to my first slide, please. And the next one. There we go. This is what the continuum of care looks like in Kansas under the CCBHC model. As you can see, we have all of the 9 core requirements for CCBHC. All mental health centers in Kansas, all 26 of them are CCBHCs in Kansas. Next slide, please. Where we are at, we have a state plan amendment to our Medicaid policy effective 1/1 of 2026 for the implementation of DCO5. In that state plan, we managed to secure funding to provide the training free of charge to all early childhood diagnostic teams, meaning pediatricians, family doctors, mental health professionals, those that work with children 0 to 5. In that, we have also started working on a billing guide that will help with training, implementation, and sustainability. We've built in train the trainers so that after this first year, we'll be able to do a lot of our own DCO5 training to help it be sustainable in the state and to make it available free of charge to providers. One of the things that we've been working on through the 0 to 3 financing project is bringing voices to the table. As you can see in Kansas, we have lots of people that are working on 0 to 5 services and improving services and connecting people. This is just a list of the things that I participate in working on 0 to 5. Next slide, please. In working on the DCO5 implementation and the 0 to 3 financing cohort, we were trying to identify what does the workflow look like in Kansas? Where are we getting services? Where are we getting referrals? Where do they refer to? And so we built this pretty basic referral workflow. And originally our audience was pediatricians, and the more we dug into it, we decided that really nurses that work with pediatricians, family doctors, other providers that provide diagnostic work for children 0 to 5 is really our audience, because that's usually who's referring children to services. As you can see, there are multiple places to be referred within the system. It may be a Part C providers working with the family in the home and they have some developmental concerns or some mental health condition concerns, and so they refer them to the local mental health center to be evaluated. Or it could be a referral to the Part B, which is for schools from 3 to 5, and they identify that there are some concerns that need to be addressed and refer into the mental health center. We found that in a lot of our communities that a shared language is very, very important, because when I say Part C, that means something to somebody, but it may not mean the same thing to someone else. When I say IECMH, that means something. If I say Rainbow United, everybody's like, oh yeah, I know what they do. So visiting with one of the mental health centers, I said, well, who's your Part C provider? And they're like, we don't know what that is. And it's like, okay, we definitely have a communication gap somewhere. So we are working on bringing together all of the different entities that serve children and trying to get together a shared language so that when we're referring to other people or we're recommending that you check out services somewhere, that you understand what those are and where they're provided. We had a convening recently, I think it was last month. We had 56 different organizations come together that serve 0 to 5, and we had 85 attendees from those organizations. They were mental health centers, maternal health, early childhood mental health, home visiting, early intervention, state agencies, managed care organizations, pediatricians, child welfare, public schools, early care and education, child care, and many, many other organizations joined us. And we talked about this same vision of trying to get all of the entities that are serving children in Kansas. What does that look like, and who provides what, and how do we get access to those services? Next slide, please. These are the actionable items that we have come up with being able to leverage CCBHC for the early childhood. Trying to identify in the CCBHCs what have they have done to improve services 0 to 5. In Kansas, if a child was less than 5 years old, a lot of times the mental health centers would say, whoa, we can't do that. We don't know what to do with children younger than 5. Well, with CCBHC, they can't do that. So now we're trying to identify what is it that they need to be able to serve children 0 to 5. Is it training? Is it, understanding of brain development? What exactly is it that they need? We have play therapists, and play therapists are prepared to provide that service, but there's not enough of them in the state, of course. And play therapy is not the only thing that can be done to serve these children. So we've had that conversation. We're working with our Association of Community Mental Health Centers, and we have a work group that's working together that's trying to identify what is it as a clinician do you need to be able to provide a mental health service to a child less than 5 years old. That has opened the door to you don't know what you don't know. And so we are getting closer to that. One of the things that we've worked on is building a crosswalk between our Part C, our Part B, and our mental health centers so that we can have a heat map of who serves what areas, so that when we're talking to communities, we can say, this is your mental health center. These are the counties that it serves. This is your Part C provider. These are the counties they serve, so that we can open that door to communication, because a lot of times they have a working relationship and they don't even realize that that's who they're working with. They just know that Jane down at the health department is who they get connected to when they need home visiting program. And they don't understand that the home visiting program is part of Part C or the IECMH. Go ahead and go to the next slide. And then these are the measures that we're putting in place for mental health centers to start tracking so that we can see the increase in services being provided and helping us identify the progress that we make, and then being able to identify how many people are actually providing these services. On this, the capacity for the CAME is the Kansas Association of Infant Mental Health, if anyone didn't know that. And how are we expanding those services in the state? Our ultimate goal is, of course, is that we have this great working network that everybody knows what everybody else is doing, and that children are not just sent willy-nilly places, that they're actually getting connected to the services that they need, along with the family support that they need to improve their home life and their development. And I believe I'm done. There we go.
Thanks, Linda. Hi, everyone. I'm Sarah Kelly Palmer, and I work at Family Service of Rhode Island. You can switch to the next slide. And I'm really excited to be here to talk a little bit about how we've incorporated infant and early childhood mental health into our CCBHC clinic. You can switch to the next slide, please. FSRI is one of 8 state-certified CCBHCs in the state of Rhode Island that launched in October of 2024. So our state CCBHC just actually had its first birthday, and we are part of the federal demonstration. So even though we have 8 state-certified CCBHCs in our state, only 2 of them actually have specialized services for the 0 to 6 population. And I share that because as our agency went through the planning process for our CCBHC, that went through our cost reporting for our CCBHC, we found it to be a very adult-focused process. That doesn't mean that's how it happens in every state, but that was our experience here in Rhode Island. So to Lisa's point earlier, when I'm looking at our manuals and our policies and our procedures for our state CCBHC, there really isn't that much intentional language about the infant and early childhood population in this space. So we can use some improvement in that in Rhode Island. I do think our agency was in a unique position to kind of call out the importance of this, because we do have a pretty robust service array that goes beyond our behavioral health care, that includes a whole division for early childhood services, several home visiting programs, early intervention. So I'm very excited about the release of this toolkit, because I do think it can make a really big impact for so many CCBHCs that I think want to help this population, but they aren't just, they're not sure how to go about it to take that first step. But we worked real hard as our own clinic, doing education with our state and really advocating for this population to be included. Next slide. So one of the ways in which we were able to really advocate and call out this population was through the completion of our CCBHC community needs assessment. As Lisa mentioned earlier, all CCBHCs are required to complete a community needs assessment, and that really can become your roadmap as a CCBHC for your staffing plan and your service array. So you did hear earlier that all CCBHCs have to deliver a set of 9 core services. But what the needs assessment can do is it can really help to inform where you might specialize your services, or where you might bring in designated collaborating organization to fill in gaps in care. From our needs assessment, we really made an effort to cast a wide net of stakeholders when we did our focus groups and our surveys. And we were intentional to include child-serving entities that come into contact with children 0 to 6. It became very clear through that process that there was a gap in the early childhood and infant mental health space. At the same time we were doing our needs assessment, our Executive Office of Health and Human Services at the state level actually had convened an infant and early childhood mental health task force which was very helpful to us, that had just issued a set of recommendations that reinforced what we were finding. And you can see here, this is just one set of statistics that I pulled from that report that shows you the number of children here in Rhode Island receiving Medicaid ages 1 through 5 who were presenting with serious emotional disturbance. And as you can see, the number is really on the rise, which we don't like to see. But it really helped to reinforce the need to specialize in this area. Next slide. So what we did as a clinic was we really looked to see what evidence-based treatments were out there, and based on our needs assessment and what we were finding anecdotally, what we could lean into to offer in our clinic. So we picked parent-child interaction therapy, also known as PCIT, treatment for 2 to 6-year-olds. And we intentionally put this in our CCBHC certification plan, which meant that all costs related to training, costs related to kind of supplies to implement the treatment with fidelity were put into our cost report as a CCBHC. One unique thing about PCIT is that part of the treatment utilizes a one-way mirror where the therapist is on one side of the mirror and the child and parent are on the other side. The parent wears an earbud so the therapist can coach the parent, practice skills that they've learned with their child in real time. So prior to our CCBHC, I think thinking about the costs related to the training, implementation, making sure that our rooms had one-way mirrors, purchasing all the technology seemed a little overwhelming. But with our CCBHC certification, we were able to really leverage that to include those costs in our cost report. Next slide. I'm going to give you a little peek at one of our PCIT rooms that we were able to update and outfit. So on the right there, you can see the skinnier picture is where a therapist would sit with all their fun technology, and they would be looking into a child and parent on the other side. And we bring in toys that are kind of specialized and suited for each child, each client as they come in. So this is just to highlight the fact that CCBHC can be a really great way to bring in an evidence-based practice that perhaps your clinic or agency couldn't do so before. Next slide. The other evidence-based practice that I want to mention is the Mobile Response and Stabilization Services, also known as MRSS. So you heard all CCBHCs are required to offer crisis services for both adults and children. Here in Rhode Island, our state actually required that all CCBHCs must offer MRSS for children and youth as their model of mobile crisis response. So while MRSS is not a treatment that was designed specifically for the infant and early childhood mental health population, it really can be a powerful treatment and way to connect with families with young children when they are in crisis and can help engage them in care. Catherine mentioned the importance of training crisis teams in infant and early childhood mental health, which is highlighted in the toolkit, and you can do that with an MRSS team. What is unique about the MRSS model, and I think makes it really friendly to serving infant and early childhood population, is that it works from the principle that the crisis is defined by the family. So let's say, for example, there's a family who has a toddler who's having a really difficult time with self-regulation. They may be struggling at home. They may be at risk for being asked to leave their daycare. The parent or daycare could call our MRSS team if things were escalated. We could respond within an hour from the time of the call. We would send a clinician and case manager to stabilize that situation, conduct a clinical assessment, make a safety plan if necessary, and then we could follow that child and parent for 30 days for a stabilization period where we could wrap around them, provide referrals, and perhaps engage them in an early childhood mental health service. In our clinic, we are finding that our MRSS services are really a way to engage families with young children in care who may not realize that mental health services exist for babies or young children. So those are just 2 treatments that we in Rhode Island are leaning into for this population in our CCBHC clinic. So now I'm going to turn it over to Christine March from Oklahoma.
Thank you, Sarah. I'm happy to be here today, everyone. We can go ahead and go to the next slide. I'm here to really talk about how, as a CCBHC in Oklahoma, we are one of 13, and how we really changed some of the components of our processes when we became a CCBHC. We moved from a community mental health care center to a CCBHC. And because of what you've heard a little bit about already, some of the requirements, as well as some of the way we're reimbursed because of our cost basis, we were able to incorporate some additional components into our onboarding, our interdisciplinary team approach, and our peer consultants that really changed the way we provide and support infant mental health and the services we're providing to the families. You can go to the next slide, please. So part of what we do when we're onboarding our staff that changed really when we became a CCBHC is really wanting to make sure that we're incorporating all of the infant mental health components into even the interviewing process, looking at that as we're onboarding. Some of this happened before being a CCBHC, but with that shift, we are also able to provide the infant mental health and early childhood mental health services, I want to say more in alignment with the model that is recommended. And that being said, before, when we were a fee for service or whatnot, we would have to be really leery of how much time we had to spend with a family. And with the CCBHC model, the model really supports the amount of time that our caregivers and our young children require to have in treatment. And so when we're interviewing individuals, even to come in as our workforce, we need to take that into mind that they need to appreciate that as well. So if we have individuals we're interviewing who believe that they're going to come in and do play therapy only and work only with young children and not really have a lot to do with the caregivers, the whole philosophy of infant and young child mental health is that our caregivers need to be a huge component of the services we provide. So just upon the interview component and the training component, we are interviewing and training our individuals that we hire into our workforce during that onboarding period on the CCBHC model, and also the role they play within that model. Because we have the team-based model in the CCBHC model, their position in there is not independent as one might have been accustomed to in other service models. So if you used to be a therapist in a CMHC or private practice or whatnot, you may refer out, you may collaborate in some ways if you need to on specific families, but you're not necessarily a part of a team. And so as we are onboarding our staff into our current CCBHC model, they are part of a team. And I'll talk about that here in a little bit. The rest of the onboarding training is also part of our collaborative service goals, which we do talk about productivity, and we also talk about dosage. So we know that our young and early mental health children require a different amount of dosage for the services that we're providing to them. Just because they might not be at high risk as some of our other individuals or youth that we serve, they could be high risk defined differently depending on their developmental needs or their family crisis needs. The example given earlier, even about a child being kicked out of daycare, can start becoming very risky and difficult for a family to manage. So those might be reasons that for a young child, we would have them at a higher level of risk. And so we need to look at how our dosage and how often we serve somebody is going to be determined on a caseload. And then secondly, or excuse me, fourth bullet point for onboarding staff is our supervising. And we've already talked about and know more about when we're working with families and young children, our staff need a different type of supervision. And I honestly really have struggled with this because I feel like all of our staff need that same level of supervision. But we do know in our programs with young children that we have our reflective supervision and our consultation that is ongoing, as well as the administrative and clinical supervision that we're providing. So as we're onboarding our staff, we're incorporating that into place. And a lot of times when we're hiring new workforce, they're not accustomed to having that kind of supervision. And so that's something that we're also helping them recognize as they become a part of a CCBHC. Next slide, please. So I mentioned a little bit already about our interdisciplinary team. This was new for us. We had to really look at how are we incorporating our therapists, our care coordinators, our family peer specialists, a nurse, our child psychiatry that's part of our agency core team, as also, working with our collaborative teams that are external, whether that's child welfare, Head Start, maybe a daycare provider, et cetera. And so this was very new and different for our teammates. It used to be you could be a therapist, and if you needed somebody to do case management, you did it yourself. If you needed to make a phone call and collaborate, you did it yourself. You had to be the one-stop shop. Now we have a whole team approach to really work with our family and our children. And as we've gotten used to this internally and had to train on that and really work to develop that communication and how are we trying to seamlessly support this family, we've also had to train our families on this. Families who come in to see us in a CCBHC model aren't necessarily aware that they're going to have a whole team as part of their team. It's not just a therapist or just a case manager. They're going to have several people on their team that they can call on to help and support them. A lot of times our families believe I have to have weekly, 1-hour therapy sessions. You're going to go take my child and you're going to fix them. So we've really had to work with this interdisciplinary team to be specific, informative, and educational with our families so that they can see we're all here to walk them through the process and help them be successful in this. So part of the training that I even mentioned before is how does a family peer specialist understand children's mental health? How does a care coordinator understand children's mental health? If you have an evidence-based practice like parent-child interaction therapy that we just heard about, how does a care coordinator have a role in that? How does a family peer specialist have a role in that? And so we have specific training curriculum for each of our teammates on our team of how they're going to carry out those evidence-based practices as well to all support that caregiver and the child and the services we're providing. Next slide, please. And then our peer consultants, who I just mentioned, our peer consultants have the lived experience. And we have peer consultants that work with our infant and early childhood caregivers and our care coordinators and our therapists. And they're so vital to our team. They're often our individuals who help orient our family into our service array. And they're the folks that are out there talking and walking side by side our caregivers as they're learning how to understand their child better. So a therapist or a care coordinator might be able to help with coordinating referrals or getting food or some of the basic needs kinds of issues that our caregivers run into. And our therapists can certainly be there to help identify ways that they can interact or understand their child's development. But these peer consultants are the ones that really kind of glue it all together for us. Our caregivers tend to listen to our peer consultants a little differently than they do some of our other teammates at times. And we've really seen that these peer consultants can reduce that stigma and really help these caregivers walk that walk and walk through this process because it is difficult. We know that our caregivers are often stressed when they're coming in. If they have a young child or an infant, they may not recognize or believe some of the impact that could be happening to their children, all the things that we know about infant mental health. And so we really try to use our peer consultants in a way that the model allows us to use that in the past we weren't able to do. So as you can see, the CCBHC model has really brought into play a couple of different dimensions for us as we're providing evidence-based or best practices to our families by offering a whole team, a whole variety of people who can all say and share the same concepts, and it's not all falling on one individual, one care coordinator, or one therapist to try to be everything to everybody at one time. So the model is what has really allowed us to do that. And we had to really figure that out. It took us a long time. We're still always working and planning on how to make it better, but that CCBHC model helped this become alive for us. So I believe now I hand things off to Lindsay. Thank you.
Thank y'all so much. So now we are going to shift into some discussion so we can hear a little more from Linda and Sarah and Christine, and the other folks from our team, and Anne can pipe in too if they'd like to. So we'll go ahead and pull the slides down and just bring everybody up. And I was looking through, we had a few questions in mind and in advance. And I was also looking through the questions that have been coming in from those of you in the audience. And so I want to start by maybe pulling on a couple themes and hearing what thoughts they spark for y'all. So the first theme is around thinking about data and measurement and evaluation. So a specific question that came in the chat was for Linda, asking, how is Kansas measuring 0 to 5 access and caregiver mental health engagement? That is so cool, side note. And then I'm wondering, maybe Linda could take that question specifically on 0 to 5 access and caregiver engagement. And then I'm also wondering for Christine and Sarah, if y'all have thoughts of how are you thinking about data? How are you looking at, how do we know if we're meeting the needs of the population we're looking to meet? How do we know if what we're providing is quality and having the impact that we desire? Any thoughts that are sparked for y'all on that? Belinda, you want to start us off?
That's a great question. And if I wish I had an answer for you, because that's where we're at, is evaluating how do we define that, first of all, and then second of all, how do we measure that? Because we're not going to ask a 2-year-old how their therapy was. It's going to have to be the parent or the caregiver that gives us the input to how that helped, didn't help, maintained, improved. It's going to be up to the caregiver. So that's part of the process that we're in now. We're right in the middle of doing next year's participating agreements where those measures will be put into place. So it's a great question, but unfortunately I don't have a specific answer for you.
I can jump in, Lindsay, if you like. So we are just a year in to our state certified CCBHCs here in Rhode Island. And I think for us as a clinic, we're really interested in looking at access and if we are reaching, right, this population. So we're doing that at kind of a broad level from our clinic, but also program by program. So I mentioned MRSS, right? So I know that within the first year of our CCBHC, I think about 6% of our calls were kids 6 and under, right? So for me, and this seems like a really simplistic thing, we're really going to be looking at that in the coming year, kind of quarterly. Are we increasing that number and reaching those younger families? And not that I want young children to be in crisis, but we know those families are out there, right? And we know that they're either showing up to the hospital or they're showing up in our child welfare system. So we're gonna work, Lindsay, on kind of like really looking at access for this population and if we're moving the needle. Because one thing that I found when we implemented PCIT, I really thought we'd be flooded with referrals. Because we know the need is there, and really we're having to do a lot of education in this space about just that this is out there and that young kids can benefit from it. yeah, so I think we're going to really be looking at moving the needle on the number of people young infants and early childhood kids we serve. So, but I do know our state hasn't really been breaking it down as a kind of specific population, which I think could be really valuable.
I would agree too. I think some of the things that we ran into from the beginning and our state has really tried to address are what are some of the outcomes that we're using that are good for the entire lifespan of working with children at least. And we have some skills that we are using that the caregivers can fill out so that we can try to see better outcomes. So for example, we're using the Ohio skills in the state of Oklahoma, and while we came out of infant and early childhood mental health, and personally, it's like why are we using Ohio skills? Why are we not using something specific to young children? That is the difficult thing, is how to find an instrument that can be used broadly, but also give us relative information. And so that's one of the things that we're using. We also measured access to care in terms of how fast to get people in, and we are able to manage within that 3-day time period and manage walk-in services so that anybody can come in at whatever time is available to them. And with children, we've really seen that as really important, because sometimes you don't know when it's going to work for you, and it might be that you just need to up and go that day. We've also been allowed to have an appointment without the child present if need be for part of our evaluation, and the evaluation component is extended. It's not a one-time intake and you have to get everything. It's really meant to be broken down over time so that you can have the information and the attention needed. We know you can't sit with a child for 2.5 hours for an intake appointment, for example. So I know I'm swaying from outcomes, but those are some of the really important things that I think that our state tried to look at as we're working with families and younger children.
I really appreciate the way you're describing sort of looking at every layer of the work and every part of the process, and just kind of asking yourself, like, does this make sense for young kids? Does this make sense for young kids? What would it look like if this made sense for young kids? And that, I think, is such a important inventorying process when thinking about how to leverage this opportunity maximally to meet the infant toddler population's needs. On that kind of an adjacent thought there, thinking about like you were sort of touching on this, Sarah, even in thinking about, we've built this thing, but the demand for how do we build the demand side, I imagine a lot of that relates into kind of leveraging those connections to other parts of the system, other service delivery settings, other providers in the ecosystem. And I'm curious, we had one specific question that came in around whether any of the CCBHCs have incorporated occupational therapy to support the regulation needs of young kids. And that had me kind of thinking about, integrated care within a clinic and also connections to services outside of a clinic. Linda, you referenced Part C, familiarity, early intervention services. And so I'm curious if y'all have thoughts about maybe places where you've had success building those pathways, or places where you've thought about bringing in more integration of services, or anything that might be, any thoughts those might be bringing up for you.
We have one CCBHC that's being very innovative in what they are doing. They are doing some more integrated in-house services for children with dual diagnosis. So they're really focusing in the autism and the IDD population, where they have actually hired ABA therapists and other BCBAs to focus in on that population so that they can identify the behavioral part of the behavior and the mental health condition that drives that, so that they can focus in on what does this family really need? You know, talk therapy is not beneficial for a 2-year-old. So what can we do to help them? And so they've brought that ABA perspective in, and they're partnering with a couple of our universities to hire some interns to come in and do some of that work where they actually have clinical oversight also. They also have what we call a crisis respite program where they are providing planned respite for children with dual diagnosis, which is the only one in the state. So we're piloting that there to see how that works. So far it's been good, but they just opened in August, so we'll see how it continues.
We would agree that the integration of the health and behavioral health is just paramount. And so our CCBHC and some of the others in the state have worked to have more of the physical health components be a part of their system, even if it's another entity embedded with them, which is what we've started doing, or definitely the referral process. But having nurses being a part of our team was new to us as a CCBHC as well. And what a game changer when you're looking at some of these youth and infants and children who trying to understand what their physical health needs are as well as their mental health, and trying to peel away and see what other kind of testing do we need, what other kind of maybe referrals to specialists do we need, that we can help this family find and link to. So along that, testing has been something that we're moving toward more as well, because we know it's very difficult to find anywhere. And so making sure that children start off with the right testing and get on the right pathway to help support them preschool years and then into the school age years is paramount to get youth and families on the right track. So absolutely, we're seeing more of that integration.
I would just lastly add that I think in our clinic, we don't have dedicated OTs as part of our CCBHC, but I think, and Christine had mentioned this earlier, our ability to do kind of deeper care coordination because of the CCBHC model and our teams, I think is making it a lot easier for us to connect with our early interventions and our home visiting and, leveraging those other programs that have those resources built in. We're now able to do that in more of a real way than we were prior to implementing CCBHC. So.
That's great to hear. Thank you. Another question I was wondering about, and Anne, you may have thoughts here too, to bring from like the national perspective of what different CCBHCs are doing or what's built in to the model. But curious, how do families of infants and young children provide input to CCBHCs about their unique needs, the services they would like included, or the things that they need to access, and the ways that access is promoted? And I saw a comment in the chat talking about like language accessibility. And so I wondered too about, and maybe this connects in, Anne, with some of the like community assessment and some of those pieces. But curious about that, of sort of how are the families of young children in the community informing what's being provided within a CCBHC?
Yeah, I'm happy to highlight kind of what's wrapped into the model, and then I would love to hear from Christine and Sarah on how they've done that out in the field. So there are two pieces that come to mind immediately. So the first is that community needs assessment, and so that's really where the CCBHCs should be looking out into the community, figuring out who's out there, what do they need. It's very comprehensive. It is outlined within the criteria what's required. And a piece of that is focusing on the child population and their behavioral health needs. So that's one opportunity as it's built into the criteria. The other is in the organizational authority domain. And so this is how the CCBHC structures their board, essentially. And so there's a requirement for CCBHCs to have 51% of their board and if not their board, an advisory group of some kind. But 51% of that group should have lived or living experience or be family members of people with lived or living experience. And so that's a really key opportunity for CCBHCs to think about how broad that group is for the people that you're serving. And so if you have a large IECMH population, then maybe part of that 51% should be a parent or caregiver. So those are two opportunities that come to mind built into the criteria.
Sarah or Christine, do y'all have
Yeah.
any thoughts, or Linda, do y'all have any thoughts from the, like, at the clinic level?
Yeah, I agree. Those are the two things that come to mind for, I would say, families who are not already involved in a CCBHC. I do think it is on the CCBHC to be intentional about who you go to for your community needs assessment, because again, I mentioned our plan experience was very adult focused, kind of from above. So I know other CCBHCs that didn't even think to go to a daycare to ask what needs they had. So I do think that's why this toolkit's so important, right? To kind of shine a light on that. But for current clients, we have several touches. We have a patient experience of care survey. We do have a consumer advisory board, to your point, and we often have town halls and things like that to kind of get the ongoing feedback. But I do think that community needs assessment is a big piece of the puzzle for sure.
And I agree with that. And most, at least in our state, we are requiring that they do that needs assessment every couple of years so that we can expand to those organizations that we didn't think about when they did it originally. And we have a quality assurance team that goes in and does auditing of the CCBHCs, and they're identifying areas where they didn't do enough needs assessment saturation so that they can be sure to include that next time.
I would agree with that. I think when if you look at a snapshot of services provided across the state, the majority, of course, are for those 18 and over. And because of that, I think that's where a lot of the funding had leaned in initially when we had sole source contracts and some other dynamics before CCBHC. Child has always been smaller, and then gosh, when you get into 0 to 3, 0 to 5, it's even smaller. And it's really the states need to drive a lot of making sure that that is included in the spas, as well as in our requirements in the manuals, etc. And I think that we've tried to do that, but like you say, everything we do, every process we put into place, every workflow we put in place, we're trying to look at it through that lens of a family coming in and a family with young children coming in and everything else at play. I know in Oklahoma, in different spots, we're really lucky in Tulsa because we do have a community team that our Department of Mental Health spearheaded years and years ago along the model of systems of care. So it was prior to even the CCBHC model. And that has been an entity that has all those people there from, or many, we can't ever be, perfect, but many of our young child and early childhood folks are at that table. We need to get better at DCOing. We need to get better at understanding how to DCO. And we need to really work with our state to figure out how to do that in a more comprehensive way. And, when the states are having funding issues, that can be difficult, but we're still trying to do that. So, there's still a lot of room to go with how to incorporate having family voice in what we're doing.
Thank you all so much. This has been such a rich session. It's been really wonderful to hear from all of you. And we hope that this has given everybody a solid sense of what is available in the toolkit. If you have any questions for us, feel free to reach out. Kathy on our team is available and can field any questions that you might have, or if you want connections to more information that we've covered. Earlier in the chat, I had put a little information about the financing policy project and an email address to our colleague Alex, who you can reach out to if you need connections into that project or you're interested in having your state join next year. We are so grateful to our panelists, our state and community panelists, and our colleagues, and to Anne from National Council for all the incredible work they've been doing. And we will part with letting you know that the toolkit is up and live, so we'll pop the link into the chat. And then we wanted to, on the next slide, just give you a heads up about an upcoming webinar where we'll be talking with folks from Minnesota about ways that they're really innovative ways they're looking at better addressing fetal alcohol spectrum disorder in their state. So stay tuned for the registration for that. And thanks so much for joining us. We hope you have a great rest of your day.